Welcome back to Radical Health. Thank you for joining me. I'm your host, Seth. This is the show where we talk about all things related to health. Now, some of you may already be aware that I'm pretty outspoken against Western medicine and very much in favor of natural healing. But there are some times when we might need Western medicine, whether we don't prevent that certain disease from manifesting or we get into an accident and intervention's needed. I wanted to take one episode just to highlight some of that type of healing. I want to highlight the field of healthcare workers to show that despite it not being a perfect system, they are truly in it for good reasons. Now, I happen to know a particular doctor quite well, so I asked him to do an interview with me and speak on hospital medicine. Back in 2009, he had me come film a demonstration that he did at Mass General Hospital, where he intubated himself in front of a class of brand new doctors to sort of destigmatize the procedure of an awake intubation. Anyways, it worked because this video became super popular in medical training and EMT circles over the next few years, raking in 1.5 million views between Facebook and YouTube. And I still get comments to this day on the video on my YouTube channel saying how they want teachers like him, how rad this guy is, how they need this energy in medical training. If you want to watch this video, it's less than 5 minutes long and it's on my YouTube channel, youtube.com/Seth Bailin. The name of that video is Awake Endotracheal Intubation, so you can search for that as well. Anyways, the guest on today's show, this doctor, he plays a few roles in my life. He's a teacher to me as well. He's always instilled a sense of the importance of learning. He taught me how to play the saxophone when I was a kid. He always encouraged and supports new endeavors that I'm involved in and choices I make, even if he doesn't completely understand them. This guy is my father. And I'm proud to bring him on the show today for him to share some of his experience in hospitals, some of the techniques used, some of the drugs used, and also some of the unorthodox techniques he might employ. And at the end, we get into some of the new fields of medicine, such as addiction medicine, harm reduction, and end-of-life decisions. That's a really interesting one. So without further ado, I'd like to give a warm welcome to anesthesiologist, educator, mentor, advisor, administrator, and my dad, Dr. Michael Bailin. So you've held a variety of positions in your career, from technician to general anesthesiologist to, advisor for medical students to chairman of Anesthesia Society. What were some of the early positions you held that really shaped the way you see anesthesia today?
Early on in the first leadership position that I had, or the first position other than giving clinical anesthesia, was chief resident of anesthesia at MGH. And we had 27, 28 residents a year. And we had 2 or 3 classes at once. And, so 50, 60 people to help organize their schedules and be a little bit like patrol leader in Boy Scouts. And that was my introduction to conflict. So that was really interesting to navigate and be able to weigh a request like, I forgot to ask, my sister's getting married, in a month, but I'm on call that weekend. Can you fix that? How could you forget your sister was on call? Well, anyway, that's the situation. Now I've got to help one of these young doctors get out off the call schedule. Or one of the young doctors feels that they've been not fairly treated by a senior doctor, and they come to the chief resident for help. And now you need to navigate that place between the staff physician and resident physician, and there's politics and there's rights and there's complexity there that I just learned really for the first time about. So once I got onto the staff, the medical staff, MGH and probably all great hospitals have the mechanism to advance young people by making them part of committees like a transfusion committee or a resuscitation committee or an education committee or a nomination committee. And by getting into committee structures and learning to listen to others and also seeing what real life problems are in this social environment of a hospital, where it's not just about taking care of patients, but taking care of each other. Those were the most formative times in my career. And as early as the mid-'90s, so I graduated medical school in '84, finished residency and fellowship and chief residency in '88. And by 1995, I was already applying to be chief of anesthesia at Boston City Hospital, which I was offered and didn't take for various reasons, because I felt I wanted to become part of the leadership structure now, formally. And I first did that in 2002, applied to, accepted, and went to Worcester Medical Center in Worcester, Mass. To become the chief of anesthesia. Shortly after that, I took another chief job at Miriam Hospital in Rhode Island and was the chief of anesthesia there. And then some years later went to Bay State Medical Center to become the chairman of a large department where we had 130 people giving anesthesia, and in a hospital that does $2 billion of revenue a year with 12,000 employees. And so a lot of where my clinical work was having me feel really satisfied that I was helping people and caring for patients. I felt that being in administrative and leadership roles could help me take care of the people that were caring for the patients, and that just gave me a satisfaction that I really enjoyed.
So that sounds like a role where you're mentoring other doctors. Can you tell me a little bit about your experience mentoring potential doctors and prospective doctors, medical students?
Sure. There are many kids from high school and college that I come across in any number of ways, either through my volunteering or social activities, or my friends might have children or others that make contact with me. And I almost always will give them 30 minutes or an hour of just an introductory meeting and say, one of my favorite sayings is, this is worth what you pay for it. And of course, they pay nothing. And so it may very well be worth nothing. But if you find it valuable and you want to speak more, I'm always available. So I have literally now somewhere probably actively advising 15 people, high school, college, people who are in a career that are thinking about medicine or dental school or veterinary school, professional school of some sort, usually health related, that I either meet, Zoom with, or otherwise advise. And many of them are not quite suitable, in my opinion, for health-related careers for various reasons, and I'll give them that opinion as well. And many of them, either they're not suitable because they haven't done the prerequisites, or because they're going into it for what I think are the wrong reasons, like their parents are pushing them, or they've never really been able to sustain any scholarship for a long period of time, which is really a prerequisite for success in a profession that, especially to be admitted to school, admissions committees need to see that students have academic, not just potential, but demonstrated academic prowess. And if you don't have that, and you can't demonstrate that, and you still want to go ahead and try to do it, then you develop it. You go get yourself a master's degree or do some other type of higher education where you can have a number of courses to study, work with professors, get letters of recommendation. It takes a lot to build up a portfolio that will be successful. And you need to be doing it for the right reasons or it won't work out. I've been there, and I know how easy it is to not be able to keep on task or on goal when you don't have that fire inside.
Education is sort of the crux of advancing any art or technical study. Besides enjoying it, do you feel a personal responsibility to be an educator and to help the next generation of physicians come up?
I don't know. Certainly a responsibility, sure. But it's way more than that. I have a really strong desire to do that. And I'm the son of two teachers, and there's teaching all around me. And it's just how you teach me, Seth, and your brothers teach me, and your mother teaches me, and everything seems to be a teaching opportunity. And to do that 360, have been part of the culture. I want to continue to be part of that culture. I love learning. I love teaching. I love being humble because I really only kind of know what I know. And it's hard to know what you don't know, and my mind is always open. So whether it's being taught or teaching, I'm in.
Do you feel though like a need, like when you wake up, if I don't help this next generation, I'm not fulfilling my purpose? Do you feel any of that?
Oh, when I go to work, absolutely. When I walk in, if I'm here at home, and I might be more interested in reading a classic book or some scientific papers that came in the mail, or some to keep up to date. I have a need to keep myself updated. But when I go to work and have a hospital full of medical students, nursing students, residents, physician assistants, nurse practitioners, students of all varieties, pharmacists, then that light goes on and stays on. And as much teaching as I can get done, and in as spectacular a way as I can do it, I want to make it memorable for the students. So it's not just a little teaching here or there. It's something that will, I would love to change someone's life, a learner's life, every day that I go to work.
Can you give me an example of a teaching moment where you employed an unorthodox or different technique than someone else might have taught the same thing? Because you are known for teaching things differently. Can you give me an example of a time where you taught something on the job, the younger person got something out of it, and it was a little bit different than someone might have expected?
Sure. So things definitely jump to mind. This would be in room 42. It's Mass General Hospital. It's around 2000, the year 2000. I left that hospital, by the way, in 2011. So here we are. The residents in anesthesia have already graduated medical school. They've already done an internship, and now they're on a rotation. And they do 36 months of rotations. And this particular resident is in his 20th month. He does not need me for any reason to help him start an intravenous or to do some of the simple things. But he's down in room 42, and the idea is for him to call me when the patient's ready to go to sleep. This is a special patient. He's 10 years old, and he's about to have a kidney transplant. And he's already got a shunt in one of his arms where he would get dialysis. And the mom and dad are down there, and the poor patient, but the resident can't get the IV started. So he calls me, and he says, "Dr. Bailin, I'm in, room 42. I'm with, so-and-so." And the boy is insisting on having his intravenous put in his elbow in the vein that everyone always uses, and I blew the vein. I can't get in. So I said, "Not to worry. Let me come right down." So I go down to room 42, and the boy's got tears in his eyes, but he's holding it together, and he's pointing to his elbow, and he says, "This is where I want the IV." And it's messed up. It's black and blue, and the parents are there, and the boy's in charge. And it would be so easy just to bring him into the operating room and give him a mask, let him breathe, and fall asleep without an IV, which is also standard. But the boy is the one who's saying, and we do that for 10-year-olds. We don't have to start an IV before they go to sleep. But this boy has been getting needles for years on dialysis. He wants to be in charge. And so I say, we will get this. We're going to get Superman. Superman's going to come down and take care of things. So I go to the workroom and I get what's called a butterfly, which is a special needle on a long tube. And I use that for a reason you'll hear in a second. But I get one of we have these big garbage bags that are red, and we use them because they're hospital refuse and you need a special garbage bag. So I take the garbage bag and I tie it around my neck so it looks like a big cape. And I run down the hall and I flap my feet loudly and I jump and I land on both feet and I say, "Here to save the day, it's Superman." And now it's me. I got my cap on and my scrubs and, but now I got a red cape on and I got the butterfly and I've connected to the butterfly a drug that we never almost ever use. It's called ketamine. And there's no way I'm going to be putting a drug in his vein because the vein is blown. I'm going to stick this needle directly into the muscle, into his bicep. He'll never know. It'll go into the same place. I'm going to put the needle in. I'm going to tape it. I'm going to inject the ketamine and he'll fall asleep. So it's an intramuscular way to knock somebody out instead of the normal intravenous way. And so it fit. It's what the kid wanted. The resident learned something. The mother and father were happy. Superman comes down, and I don't know what it was that came into my head to get to do that, to think out of the box or to, but the kid's pointing, "Shoot me here." And I'm thinking, you bet I can get a muscle shot in there, not a vein shot. And that was, probably the only time in my life that, I used some type of subterfuge to, so anyway, I put the needle in, taped it down. We all got it. It's perfect. We're good. Knowing that a shot through the intravenous would make him fall asleep in 15 seconds. But he's not the expert in anesthesia. He doesn't know how long it lasts or takes. So instead we gave him ketamine. It works in about 2 minutes. And he went to sleep and we brought him into the operating room and then we started a proper IV. So everybody learned something there, including me, certainly, because I had never done that and it worked. And it just made me feel that I gave the family and the young boy and the resident and everyone a solution. And the nurses, there are obviously nurses around and they were always the patient advocate and they're looking at this kid who had been through the trauma of not being able to have an IV started. It's such a simple thing, but such a joyful thing to reflect on.
Nice. I want to go back a little bit to your education and what kind of helped bring you up to where you are today. You worked in a research lab with pigs and monkeys doing transplants, right? Can you speak a little bit on that experience and what you learned from that?
The most interesting thing that I felt on that first day was, I don't know what I'm doing. I've never put, a monkey to sleep. In fact, that first day I couldn't because I didn't know how. And then once the monkey was asleep, I just went into, I used to do liver transplantation anesthesia on babies a little bit as well. I have a long history of giving pediatric anesthesia, although you may not know me as that, associate me more with adults. But there were just so many kind of groundbreaking things for me that were new that as I gave the anesthesia, I would be keeping a little journal and writing down what it was that I did that day so that I could see what worked and what didn't work and reflect on it later, because in the middle of the anesthetic, you're really just trying to keep the animal alive. These particular monkeys were known as chimeras, and chimeras are an organism, or in this case, the monkey, that exhibited two different genotypes. They had injected the blood of a pig in the monkey and immuno-adjusted the monkey so that the monkey would express both pig blood and monkey blood. So that when the pig liver was put into the monkey would recognize the liver as its own, even though it was from a pig. And as you can imagine, to get a monkey to that state of being able to accept monkey and pig blood together. What it was monkey blood with pig stem cells that they put in the bone marrow, and then the monkey bone marrow would be making monkey cells and pig cells, so as not to reject, but to accept or be tolerant of the pig's organ. And so this was an expensive monkey. And when they lost the monkeys, which they had done uniformly up until the time I got there, that's why they wanted a real live anesthesiologist to come in. I felt tremendous pressure and really tried to use my human principles. And it's difficult because when the operation was done and the monkey wakes up, the monkey is really angry because monkeys are not known to be domesticated pets.
And they don't understand what's happening.
Oh, no. And they have big teeth, even though they're little babies. And after, by the way, a few years of monkeys, we went to baboons. So I became an expert at anesthetizing and waking up baboons as well. And by then I knew how to hold the monkey's arms in a way and get him back in the cage. And of course, when we do a major operation like a liver transplant to a human, we have them in bed for at least a day. And here the monkey's up in his cage, like from moment one. And so fortunately, nobody ever got hurt. It's something that humbles you when you go into a situation, and actually every patient does. Every patient, whether they're healthy and having a pretty benign procedure that's not known to have many complications, to the person who's near death having a liver transplant, every time I walk in the door and push the first syringe of medicines, it is a time of humility, of learning, of openness, and then, of course, knowing what the laws of physiology are, and seeing when and if the patient or animal deviates, and then being able to do a quick correction to get them back on track. So it's a meditation. It's a real, spiritual event for me to be in the operating room with a human being. And, while the surgeons are blithely going about what they do, and they need to concentrate on their stuff. And I always say the nurse in the operating room is the glue that holds all the bricks together. And I'm a brick, and the surgeon is a brick, and the patient's a brick, and he or she keeps the operating room flowing and making sure that we're all harmonious. But for me, that's the kind of pressure and the intensity that I feel.
Shout out to nurses.
Shout out to nurses. Nurses, nurse anesthetists, nurse practitioners, we're all in this together. We can't do, no surgeon, no anesthesiologist can and would actually ever be able to work without all the other members of the team.
Wow. How many liver transplants have you done or helped with in your life?
Not that many. MGH was not that busy a place. We did in our busiest year 45. And although I was the chief of the team, I had 3 other expert anesthesiologists. And of course, for most of the years that I did it, which was 14 years, there were 4 of us. So 50 to 80.
Okay. Now, an anesthesiologist is known for administering drugs, administering sedatives to get the surgery started. Can you give me a definition, your definition of what a drug is, and where's the line between recreational and medical drugs, or is there one?
Yeah, I'd have to say that there's a line. So the drug is a chemical, it's a pharmaceutical, it's a highly purified chemical that is designed to have a specific effect in a medical setting and to be administered and prescribed by and administered by a physician, typically. Could be a nurse, or nurse anesthetist in the case of an operating room. And anytime that it's not physician directed, then it becomes recreational, I suppose. I haven't really thought about making such a clear line in the sand. But to use a drug, like in the kinds of drugs we use in anesthesia anyways, outside of a procedural setting would be inappropriate and recreational, I suppose.
Because there's so many ways we use the term drug. I define it quite broadly. I think sugar is a drug. I think TV is a drug. So I'm not sure if I define it as a specific chemical, but if we were to talk about medical drugs, we would use that definition.
I think so. I don't pride myself on knowing all the chemical structures. I always memorize one or two so that I can, impress one of the anesthesia residents. Like ether, which was made popular in the 1840s, is still used today in experimental laboratories for animals. It's a wonderful anesthetic. We could use it on humans. And interestingly, in 2021, we use ether for anesthesia daily. And it happens to be not ether. It is 1-chloro-2,2,2-trifluoroethyl difluoromethyl ether. And that is our standard drug. It's called Forane. And then the one that we put people to sleep with to start before we turn on the ether is this medicine called propofol. And that happens to be 1,3-diisopropylphenol. And so these are very much chemicals, ether or phenol, and all of the drugs that we give in the operating room. One of them, the ketamine that I mentioned earlier, is abused on the street. And I think it's classed as phencyclidines. And so, yeah, I do look at everything we use in the operating room as something that's metered out very carefully, whether it's inhaled, injected, it's weighed in micrograms, milligrams, certainly all the opioids, the narcotics like fentanyl, Demerol, morphine, Dilaudid, codeine. All of these drugs are very carefully reviewed by the USP, the United States Pharmacopoeia, given their stamp of approval, and we bet our patients' lives on the purity and the accuracy of these labels.
Now, recently, in the past maybe 5 or 10 years, you've had more of an interest in addiction treatment. What got you into that, and how are you involved with that today?
I'm not as involved as I would like to be. I would very much still be interested in helping people who are suffering from the grip of any addictive habit to get out and to get it back in control. I was drawn to that because of my own problems as a teenager, and knew that the challenge of abusing drugs that made you feel better is almost impossible to beat alone. And so in the last 20 years, I seem to take care of more and more people that have been on methadone or Suboxone or one of the treatments that we use for outpatient management of opioid abuse. And I learned the pharmacology, and I started going to seminars and doing continuing education on these drugs, on patterns of abuse, particularly mothers who are using opioids while they're pregnant, and understanding what happens to babies that are born from mothers with substance use disorders. And there's a very large group in Western Mass, several groups. Franklin County especially is involved in supporting mothers and really all people who have opioid use disorder. And so I joined those groups, and so I know a lot about it. I try to be extremely sensitive when a patient comes to the hospital with a opioid use disorder or any substance use disorder, and continue to keep up to date as much as I can, but still haven't kind of gone into it as a career. But that's a chapter potentially that's waiting for me.
Nice. Would you say that your interest and involvement in this addiction treatment world was spurred by moving to central Western Massachusetts, but also the current opioid epidemic of the past 10, 20 years?
Absolutely. I felt that there was a general call to action, and I had to respond personally. And I would do that by learning the basics and then obtaining what we call an FDA waiver so that I could prescribe my for patients Suboxone. Methadone prescriptions are still through government programs only, but Suboxone and which is one of the brand names for buprenorphine, which is a drug that saves lives, as does methadone. I totally believe in this concept called harm reduction. It's better to give people, some opioid and worry about, getting off all opioids later than for people to go take heroin and heroin laced with fentanyl and other drugs that are not carefully metered out and safe. And so I did get that X waiver. So now I have not yet written my first prescription for an individual patient, but I help refer patients and people. Well, they're not patients, they're people, who need help, and to get them to centers that can give not only the medical treatment, but the social support and the behavioral support and resources and tools that they need to get their addiction under control, because it is life-threatening and it's family-threatening and it's super dangerous, and everything a physician can do. And I have been very fortunate to be a physician, and so I try to do my part, but clearly can do a lot more.
Nice. So clearly medicines can help save people's lives if they are in a dark place and need, Suboxone or methadone to help them not do heroin. I want to hear another story where medicine saved someone's life, maybe in a clinical setting. But as an anesthesiologist, do you remember a time where you used modern medicine to save the day?
Oh, that, when medical students and other people talk about going into anesthesia so they can save lives, I say that never happens. That's not what we do. We we get people to go to sleep and they have an operation, but in fact, it does happen. We save lives all the time. And it is, and I could give you dozens of examples. And the most common ones that are happening, 4 or 5 times a day right out here in Western Mass, are people who have heart attacks. They have a heart attack, you come in and you get this clot-busting drug, and we know the natural history of a heart attack. You lose part of your heart muscle, it doesn't beat as well, you can't make a proper blood pressure, and you die, or part of your heart dies. And you don't always die from a heart attack, but it's pretty serious. They can reverse this now completely, and so that no part of your heart dies. Same with your brain. People get a stroke. I have seen this so many times myself as the anesthesiologist. A patient comes in completely, we'll use the term gorked out. They're unconscious. They're unable to respond. They have no, they don't even respond to pain, certainly not to shouting in their ear. They can't move. They're still breathing because that's part of the physiology that works in a different part of the brain, but they're about to have a fatal stroke, or they're having one. And they bring them to the operating room, where I often just put a breathing tube in them to keep them breathing and stable. And the neuro people, the physicians who specialize in busting a clot in an artery of the brain, infuse a drug or take a special pincer and grab the clot, mechanically remove it or break it up, and then they're done. And this person who was unconscious and dying, and you could see the whole, on the x-ray, when they came to the operating room, there wasn't blood going to a big part of their brain. That brain was about to die. And then the clot is cleared, the brain is being perfused, the operation's over, and they wake up. It's absolutely miraculous. So there are those kinds of things that happen every day. And house fires and people come in burned and near death. And, this is not as common unless you're at a burn unit. I'll tell you a quick story from Mass General. It was February of 2003, and there's a band called Great White. And they played in a nightclub, the nightclub in Rhode Island in West Warwick. It was overcrowded. 100 people died that night.
Because they were using pyrotechnics, right?
Exactly. And the pyrotechnic display caught the curtains and the drapes, and the place went up in flames, and doors that should have been opened weren't, and over 200 people were seriously injured in addition to the 100 that died, and a large number of them, 70 or 80, came to Mass General. At that time, I was chief of burn anesthesia. So I was in the burn room every day with some of these patients, and the patients would come in every other day to get grafted, and many of these people would have died, but the modern techniques, not that the anesthesia saved them, but they need anesthesia, obviously, to have an operation. So these are just, a few of the examples that either point directly to a medicine. Just a couple of months ago, we had a patient show up at Bay State Medical Center that started off like as a pimple below his testicles, near his anus, a diabetic. And that's how he described it. And it got out of control. And he got an infection that spread. It's called, it turned into gangrene. And he came to the operating room, and the surgeons excised all the gangrenous skin. And that is half the treatment, and the other half the treatment's antibiotics. 3 weeks later, the guy's leaving the hospital after being skin grafted and, cured of that acute, life-threatening, flesh-eating bacteria, whatever, you want to call it in the media. But that's, what it was. So he had to have a lot of the flesh removed from the upper thighs, buttocks, around his scrotum. And it's not uncommon. You can look this syndrome up. It's called Fournier's gangrene. So are there and it's not immediate. You don't necessarily, except the clot busting and the heart attack reversals. There are some things that are immediate. And the final example I'll give you would be going to what we call a code, the code blue. So people stop breathing or their hearts stop for any number of reasons in a hospital. And again, I'm giving you hospital medicine. I'm not a PCP. I'm not really in the business of, health and nutrition and keeping people in the best situation they can be in. Usually always when I see them, they're in need of some procedure, and I'm just an adjunct, kind of cog in the wheel to make it happen. In the hospital, when people stop breathing or have a heart attack or otherwise are going to have a code blue called on them, they are close to death for some reason. And more often than not, it's a reversible reason. And we put in the breathing tube. The anesthesiologist shows up, and somebody helps watch the EKG and the heart rhythm, and we give some drugs, and we do the resuscitation. And on the other side, the person, often 7 times in 10, don't hold me to that number, but more often than not, whatever we were called for can be reversed. Now, you might say, well, what caused it in the first place? Was it an overdose of a drug or some medical error? Sure, any number of these things are possible as well. We create problems as well. The medical sword cuts both ways, helps people, hurts people. I think that's been proven over and over again. We obviously try to do our best. We are human. We do also make mistakes, there's no doubt.
Yeah, and that's a good point about removal of cause. I mean, through our conversations, you know that I'm very much into the terrain model, which purports that if you remove the cause, then the problem's going to go away. But sometimes it's too late for that. Sometimes you need a medical intervention, and the drugs will help get that person back to a, relatively healthy state, or just at least a conscious state where they can be pain-free. And then I do personally think there should be more ways to educate those patients on how to remove the cause later, and through nutrition and lifestyle practices, maintain that homeostasis in their body.
There's no doubt that all the things that you have taught me about nutrition and health and keeping our or working hard to make our bodies as healthy as they possibly can be. There's just so much work that needs to be done there, and that it just there's a lot of evidence to suggest that we are what we eat, and our health is very much dependent on good nutrition. And unfortunately, doctors don't get the kind of education. At least I haven't gotten the kind of education that you've given me, and pointing me to resources that I believe are compelling and scientific and valid.
Nice. What do you do that you think sets you apart from other anesthesiologists? What makes Dr. Michael Bailin unique in the hospital?
I don't know that I'm going to come up with something that is more than a description of the Gaussian distribution. There's a normal curve for all of us in a specialty. So there are anesthesiologists on one end of the curve on something and the other end of the curve, and then some that are in the middle. And on the teaching distribution, maybe I'm on one end that might set myself apart, because I will look for ways to make a teaching moment so vivid and so memorable, maybe more than someone else. But there are other things that, and there are other people who will do that. Not that I'm the best at it, but I like to kind of push myself towards that end. And then there are people who are having other special qualities in terms of their personality or techniques they use that I don't do. So I'd say that if I thought there was something that made me particularly special or unique and had to come up with one thing, it would be pulling up the chair to listen to the patient, sitting down, and deliberately spending an extra minute or two, which sometimes pisses people off. We're ready to go to the operating room, Mike. Yep, I get that, and we'll be with you very shortly. And I'm going to stay in my chair speaking, with this patient, and understand their needs.
It is not just understanding their needs and where they're coming from in their biochemistry. It's helping them feel at ease, right? And developing a good memory from their experience at the hospital.
Yeah, that's hard to do, because even just one bad meal or one bad interaction with one person can just set the whole thing off. But that's true. I'll certainly try to do my part. The time that's the most significant for me when with this chair pulling business is we have this rubric or this moniker called, these abbreviations called DNR. Do not resuscitate. So many people who are older or sicker have that associated with their name. And it means that if something happens, if God is about to take them, or their natural life is about to be over for some reason, just let them go. Well, now we're bringing them into the operating room. And now you might say, well, why are you operating on someone who has the DNR? It might be because they're, coughing up blood, and we want to see what's down there, and we need to put them to sleep for that. Or they have an appendicitis. Don't let someone just die of appendicitis just because they're towards the end of their life with cancer or whatever it is. Fix the appendicitis and let them get back to whatever it was. And so there are many situations where we're going to bring someone in, who's at the end, and they expect the anesthesiologist, they meaning the medical world, surgeons, nurses, and families. Typically, the anesthesiologist comes in and has to reverse the DNR or postpone the DNR or time limit it in some way to say, during the operation, we're going to put a breathing tube in you. That's very anti-DNR. You don't put breathing tubes. That's exactly what they don't want. And you can't rush that conversation. And then if something happens to them during the operation, you need to work through a couple of scenarios and say, well, if your blood pressure goes down and this happens, should we let you go? Or if we think it's pretty reversible, do you want us to do what we can to bring you back to where you were or where you are? And so when I see that, it's like, I put my hands in the form of a timeout on the playing field and say to people, I need 15 minutes here, or whatever it is. And sometimes it's not the patient or the person themselves that you speak with. It's the family's very involved. You did what to my father's DNR? You're, he's not even capable of deciding that, or whatever it happens to be. So then you need a family meeting and this kind of stuff. I am super sensitive to those kinds of things. I think a lot more than a lot of my colleagues.
Okay. And then as far as, tough end-of-life conversations, there's a new field of what is it even called? End-of-life decisions. And aren't you involved a little bit in, or just learning more about that choice that people can have and the legal implications of deciding when to go? Can you tell me a little bit about what you know about that subject?
Yes, and I'll point you to my friend Lewis Cohen, Lewis Cohen. Lou has written a couple of books and is working on another. And the one that I'll refer to is called Death with Dignity or Dying with Dignity. It's called The Dignified Ending, Choosing How We Die. And this is an important work because it's something that needs to be thought about when you turn 50 or 40 or when you think you're on the back nine of life, that it doesn't have to, it shouldn't be something, the end of life, that you can't think about, talk with your family about, deal with. And I am getting involved in joining a society where I'm going to get more information about end of life. And I'm thinking about it for myself, that if I get into a situation where I feel that life isn't worth living, I should have the right to choose what happens to my body. And right now, the laws of most states don't support that, that a physician can provide medical aid in dying. And I think that that's important, and I'll be working with the societies in Massachusetts, certainly, to legalize and make more available physician assistance to someone who has thought through and has a righteous, whatever that word means in this case, reason or reasons to feel that life should be in their choices, should be in their own hands.
Yeah, that's a fascinating and important and morally ambiguous topic, it seems.
The morally ambiguous part to me is not about what the individual does. The individual, I guess could find the right road and just drive off a cliff, but that's just so inelegant and so, and if they're so sick, and maybe you have Alzheimer's at that point that, you can't, your license has been taken away or your car has. I mean, you may not have the tools. So what's ambiguous is getting other people to help you assist in your taking your life. There are a number of stories in A Dignified Ending where, including the great Admiral Nimitz that Dr. Cohen writes about, that is just a compelling set of reasons where he felt and his wife felt together simultaneously, coincidentally, that the time was up. And on a particular day, I think it was actually the December 31st, the end of the year, and they did it for tax reasons even, so they could make gifts, to their children on January 1 so that they could not have, certain implications of the law or whatever. And they took their own lives. And the family supported it, and they were just getting progressively more and more infirm. Not everyone's in that position to have the tools, to have the wherewithal, to get everything in order, but they do feel that living is more painful and too painful than what they can or want to bear. And I don't have a problem with that if someone has made that decision with their sound mind.
Any other good books that you've read recently that have impacted the way you see the world?
I don't know why I always have trouble remembering book titles. And I have been doing a lot of reading. And the things that I think if I just go into the next room and tell you, and just show you a few of the books that I've been into, certainly tell you why I like them. But the reading that I like to do the most is about relationships, about personality, and about psychoanalysis. And so the things that I'm reading are either written or spoken by Jordan Peterson, psychology professor in Canada, who has a tremendous web presence. A lot of what he says speaks to me in a very deep way. And the readings of Carl Jung, the great psychoanalyst, makes me feel that I have so much more to learn about myself and the world. And so I think I'll quote those two as my favorite authors right now.
Nice. Yeah. I mean, we're always trying to expand our perspective and perception and understanding of the world. And we need to be looking to the works of others to help us do that. Obviously, a lot of the information is within, and we can access it directly somehow. But, you inspire me in the field of education to help other people come to understanding of what we know, what we have come to know, whether it's music or nutrition or medicine or you name it. So I thank you for the education that you provide to the world and to me and to yourself. I think that's equally as important, as we just pointed out. Any other thing you want to add before we wrap up on anesthesia, the role of drugs or medicines in our life, or the role of modern medicine?
I'd love to share more stories, and we won't do that now because we can have another whole session on that. One of the most interesting opportunities that I've ever had to think about medicine is my work in malpractice cases, either as an expert witness or on the other side of being sued. So that's a world that's really important to me about what is the standard of care, what is the minimum performance required of a doctor or of a nurse to satisfy the court and to satisfy the requirement of providing good care. In fact, you even need to provide good care, or can it be average care? Should it be the best care? So that's one really important subject I'd love to talk about someday. And what I'll add is how much I appreciate you as a searcher and a learner and a teacher in all the podcasts that you do, and all the music that you play, and all the light that you're bringing to the world. It is a joy for me to see, not only as your father, but as someone who's learning along with you. So thank you very much, Seth.
Thank you. I appreciate that. We'll wrap it up there and stay tuned maybe for round 2. There's a lot more we could get into. Thanks again.
Thank you.
Thank you so much for listening. If you made it this far in the show, you're great. I really appreciate you tuning in and supporting the show. That is a wrap on season 1. This was episode 10. And my goal when I set out to do this was to put out 10 episodes on health, different aspects. And we did that. I'd like to thank all the guests that have joined me on this show. You guys truly made this amazing. Lauren Whiteman, Dandelion, Brother Air, Nora Lenz, David Lawrence, 12-Step Andy, Alexandra Kenny, David Moore, Meg Ruby, Dr. Michael Bailin. Thank you to my guests, and thank you for listening. Thank you to all the listeners. Really appreciate it. It's been a true blessing to speak with my guests and share what I learned with the world. This wraps up season 1, so I'm going to take a break. It'll be a few months, and I'll be back with season 2. If you have any ideas for people I should interview or topics to get into, please hit me up. Please email me, radicalhealthzine@gmail.com. I'll consider all requests and feedback. Thanks again for listening. Big shout out. I love you. Please check out the other episodes if you haven't already. Please share the show with people who might enjoy it. I wish you peace and health and prosperity.